Hi there, my name's Dr. Ollie Hart and I've been a GP now for over 25 years. Much of that time I spent working as a GP with special interests in chronic pain management. So it's not surprising that when we set up Peak Health Coaching, Tim and I really focused it in on pain management as a great area for coaching approaches. And we want to talk to you about our whole team approach that we've developed and we think is really important in getting great outcomes for your patients. The trouble we've got is that the traditional tools that we've used, medication interventions, are increasingly shown to be not very effective. And in fact, the most recent NICE guidance for chronic pain management details that no medication, no analgesia, certainly not opiates or the gabapentinoids, pregabalin, offer much help in chronic pain. In fact, less than 1 out of 20 people gets any reasonable benefit from them. You may get some benefit from some of the antidepressants and their suppressant effect on the brain. And there's benefit being shown from exercise and some of the talking therapies. But it's a real dilemma, isn't it? So as doctors with a special interest and expertise in the area, we're increasingly drawn to modern pain education that underpins a newer way of helping people to manage chronic pain. And the Flipping Pain campaign, I think, has done really well in how to get these messages across. They spent a great deal of time researching how to communicate messages well. And these are the 6 key areas they highlight. Persistent pain is common and can affect anyone. Hurt does not always mean harm, which is a really key message to get across, isn't it? We're used to that message in our brain. Everything matters when it comes to pain, and I'll come to that in a second. Medicine and surgeries are often not the answer, as I've said, and understanding how your pain is working can be key and underpins that recovery is possible, so there's hope. So let me very briefly elaborate on some of the key messages that we go into in our education. We like to help people to think of the brain as being the protective organ, and in fact the brain makes pain to protect us and keep us safe. Now the brain does this by processing inputs. It has biological inputs, in mostly nerves from the periphery or from the spinal cord, which signal things that are going on in the body, including tissue damage. But it also has inputs from other parts of the brain, from parts of the brain that affect our psyche, like low mood, depression, anxiety, fear, and also memory of pain, past experiences and current ongoing ones. And the brain also makes sense of our social situation. And it uses these biopsychosocial inputs to make a risk assessment. It decides whether or not we need to be protected. And its main mechanism for protecting us is pain, because pain stops us in our tracks, raises our attention and adjusts our behavior. Very often that's really helpful for us. But unfortunately, at times you can have the brain misinterpreting signals or getting overwhelmed with signals that don't really pose a risk to us. And you find that people can get stuck with what you sometimes call an overprotective brain, leading to enduring unhelpful pain. So to come to our training approach, what we've realized over many years of teaching in this area is that it really helps to divide teams into the roles they're going to play. So the strategy we've come down to most recently is to have a generic half day where the whole team comes to learn the most modern pain messages and education, how to understand it yourself and how to help patients to understand it at different levels of capability that they may have. We then divide teams where the prescribers come to a prescribing focused half day, and they focus on when it's safe to prescribe medications and really importantly when it's how to safely deprescribe medications and get them off those medications we know that don't help and will very often be giving people lots of side effects and be more harmful than good. And those in a coaching role, health coaches, social prescribing link workers, care coordinators, OTs, nurses, people who are perhaps going to have a little bit more time to coach people in the self-management skills that we know work really well as an alternative to medication, come on a second separate half day. So everybody comes to the first generic half day as a whole team together and then divide to their relative specialised second half days. And then come back together as a whole team to design and plan how the system's going to work, taking into account this common approach. So this is a relatively new approach, but we've designed it this way purposefully, and our experience over many years suggests to us that this is the best way forward. And what the evidence shows us is that we can expect to achieve significant reductions in analgesics and the associated harm that may well be causing and the side effects. We certainly can put patients more in control. And when they're more in control, they have a much better chance of adopting some of those self-management skills. And in doing so, you can teach people to down-regulate that overprotective brain. And with that, you open the opportunity to improve their pain experience, have less pain and more life. And at the end of the day, I think that's what we're all after.